here. Continuing with our evaluation of this patient, we move to an apical view. Bisschen her zu mir, genau. So we have to change his position a little bit, and then we start with an overall 4-chamber view. So we want to see all 4 chambers. We have the left atrium, the right atrium, the left ventricle, the right ventricle, and we save this image. You can also try to see if there is a pulmonary venous signal present. So we need to lower probably the PRF of the color Doppler. We need to use pulsed wave Doppler, and he also has atrial fibrillation. So, and the signal is not very good. So this we cannot evaluate, but this is how you would do it for the evaluation of, for example, diastolic dysfunction. You see the right upper pulmonary vein and the right lower is basically never seen, and here would have the left upper and to some degree the left lower, and here the left atrial appendage. But in this case it's not a very good signal. So we save this loop, and then we continue to the mitral valve, and we can also change the color Doppler in length, not in width, to see the optimal signals. And what we can see is that there are some turbulent flow overall in the left ventricle present. So before we continue with the turbulent flow, I would suggest we go to the right ventricle and the right atrium, and we see the right atrium is quite nicely depicted over here. It's not the best view because he's really hard to scan from a right ventricular side, and we see the right atrium over here. Furthermore, we can measure the right ventricular function with M mode, but in this case you see again the limitation of M mode, because that's the so-called TAPSE. It looks normal, but to measure it is actually not entirely clear, because we simply have artifacts. But we can measure it, we can save it, and then we continue with a tissue Doppler measurement. We use the tissue Doppler and measure so-called S prime. In this case it's normal, and I also always save a diastolic tissue Doppler signal of the right ventricle. Then continuing, we will evaluate the right ventricle and the tricuspid valve furthermore to see if there is a possibility to measure TR, and then we use the continuous wave Doppler, and there is actually no way we can see the signal optimally. Using it like this, so changing the gain settings of the Doppler, you shouldn't do it, because when you do it like that and you do not have a signal, you simply cannot really measure it. You do not know where you measure, and normally we do overestimate the gradients anyways. So we have to continue with the left ventricle, and we tilt the transducer a bit upwards. We can also do it downwards, where we see the coronary sinus over here, and we can tilt upwards a bit, and there we see the left atrial appendage, you can see here, and this is the aortic valve, so a 5-chamber view. This we also measure. We keep in mind that the 5-chamber view is essential for the evaluation, because here we can use continuous wave Doppler across the aortic valve to see if there are relevant gradients. Let me just put this signal in the middle so that we can see the signal really nicely. So this is moving inwards, the ventricle. This is actually during the IVRT, so the isovolumic relaxation, and then during diastole. And here we have the systolic measurement. And here you see there are 2 signals. Here's a signal and here's a signal. So these 2 signals we have to understand. And how do we know where actually a gradient is? We can use pulsed wave Doppler. So in this case we can start, for example, at the aortic valve. That makes sense, because when we optimize our setting, we do see that in the aortic valve, of course, there is turbulent flow. You can also see the signal is overall incomplete, so we have to move a bit backwards to reach our LVOT. And here you can see we are now in the LVOT, and here's also a relatively large signal. So this is also our LVOT signal we have probably seen before. Now we move inwards the ventricle and see what we can depict here. And here we have the inflow, so the E wave, and also the signal. Here we have the signal in the ventricle, and this is more also a dagger shape. So there's also an interventricular gradient, but it's not very high. So 1 meter per second, this is not relevant. And like this, we can move more towards or inwards the ventricle. Let me reduce sound a little bit, but we still want to hear. We want to hear and see what the signal is like. And here the atrial fibrillation, there was a slower AFib present briefly. And here we also see there is a sort of a gradient, but it's also not that high. So we have a patient with a thickened myocardium and several gradients we have to interpret. The mid-ventricular, inner ventricular gradients, there can be patients who are really symptomatic. But overall, in this case, we mainly have an LOVT gradient, and there we simply can take a quick look. There are already measurements, but the automatic measurements I don't want to do now. I simply want to see how high is the gradient. It's in between probably 12-13 millimeters of mercury. So this is not a high gradient. We will measure everything after we do the scan, but what we want to do additionally is we want to stress the patient a little bit. You can do it on a treadmill, but you can also do it simply with a stress ball or also with the gel. So kannst du das bitte nehmen? So we tell the patient to take it and then just pump, 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 pump. So keep it closed, otherwise you will get a little bit of gel everywhere, which is also not optimal. And then look at the heart rate. The heart rate should rise 10, 15 beats per minute. The problem is in his case, he has a beta blocker therapy, and so it's not initially rising that much. But what we can do then in the evaluation, we can use continuous wave Doppler and see again how high the gradients actually become. So there was one, So there was one which was a bit higher, but overall during his atrial fibrillation, we do see the gradients. We also don't want, this is a very, very quick measurement. The gradient is around 15 millimeters of mercury. So 2 meters per second, 15 millimeters of mercury. This is not a relevant gradient in the LVOT, but we also want to measure this one here. So that's still a relevant gradient, but it was during exercise, it's below 50 millimeters of mercury. So still, that's not a big problem. Overall, the patient did drink very little today, so probably he should drink another glass of water. But when we started, I also scanned him and he hadn't a glass of water at all. And the gradients were interventricular way more. So already the ventricle is feel better. So now we continue because we also want to do strain imaging, of course. So now we have an optimal 4-chamber view and we save the optimal 4-chamber view. So it's